Hey everybody, welcome back. This is musculoskeletal and nerve trauma out of Chapter 9 in your textbook. Today we're going to take a look at some of the more common general types of injuries that occur in athletics participation that as an athletic trainer we see on a regular basis. Now, throughout the remainder of the course we will cover basically these essentials as they apply specifically to the individual body parts. But for today, we're going to just take a look at, in general, what these look like, how they're graded, those types of things. So before we do that, we're going to start off by taking a look at mechanical injury, basically the mechanisms through which these injuries occur. Then we're going to take a look specifically at musculotendinous unit injuries, synovial joint injuries, bone injuries, nerve injuries. And then to wrap up, we'll take a brief look at mechanics and how they influence those injuries. All right, now trauma in an injury form of the definition, as your textbook says, is physical injury or wound that's produced by internal or external force. Now, an example of an external force would be another opponent or a teammate for that matter, whereas an internal force would be something like an avulsion where the muscle contracts and actually pulls the attachment point off of the bone. Okay, in some instances we're dealing with trauma that involves both internal and external force. In the case of a concussion, we may have a direct blow to the body and then the brain moves within the skull and we end up with an injury there as well. Now, trauma results from force or mechanical injury, and it changes the state of rest or the uniform motion of matter. In this instance, we're talking about tissues of the body or the body in general. And our body's response really depends on which tissues are involved because each tissue has a different inherent strength and weakness. Now, another definition we use is that of load, and this is when we have an external force that acts on the body and it causes those tissues to respond. Stiffness, on the other hand, is not what we're usually thinking about. If we say, oh, I lifted yesterday and I'm really stiff, that's not what we're talking about here. Stiffness is a mechanical property that tells us how much a particular tissue can resist load. So the greater the stiffness, the greater the magnitude that tissue can resist. So for instance, bone has a significantly higher stiffness than adipose tissue or muscle tissue for that matter, just simply due to its inherent makeup. Now, when we talk about stress, we're not talking about stress like, oh, I've got a lot of exams, I'm stressed out. Here we're talking about that tissue's ability to resist load. Okay, so what we see here in this stiffness curve is that stress is exerted on tissue. Okay, and as the stress goes up, the stiffness or the tissue's ability to withstand that stress is kind of put to the test, and eventually that tissue will begin to fail, and that's what we call a yield point. Okay, and this is where that tissue starts deforming or it otherwise starts to fail, and eventually it will fail completely. Okay, now what you see on half of this chart is shaded as elastic properties, and that means if we remove the stress, the tissue returns back to its ordinary or starting shape or length. And when we see these plastic changes, this concept of creep tells us that we're going to have at least a period of some deformity. It may not ever return back to normal length or form. Okay, so strain tells us the internal change in that tissue. In the case of muscle tissue, for instance, we're talking about the length that results in deformation. Now, the yield point is important because this is the point at which the elasticity is almost exceeded. So I've got a spring here. If you've had a metal slinky, this will work. If you've got a plastic one, it won't work. But if you were to get a friend and one of you held one end of that slinky and the other held the other, and you took a step apart and one of you let go, that spring would recoil. Okay, from one step apart, 24 inches, or if you both took a step apart, 48 inches, however long that is, you have not exceeded the tensile strength of that spring, and it will recoil, it will return. However, if you keep taking steps back and repeating that process, eventually you will reach a point where that spring won't recoil, and it'll just fall to the floor as a stretched out mess of coiled metal. Don't ask me how I know this, but I'll just say it involved a friend, his older brother Slinky, and a spanking from my mom when we destroyed that. But anyway, if this deformation persists in our tissue, then eventually there will be permanent changes. And when we say permanent, that doesn't necessarily mean forever. In some instances, it may just mean a day or two. But they are lasting is probably a better term rather than permanent. If we significantly exceed, then that tissue may fail altogether. Now, there are several different ways that tissue can be loaded. The first that we'll talk about is compression, and this is when forces result in the opposite ends of a bone or a muscle or soft tissue being forced toward one another. This is the primary mechanism of injury, MOI, in a crush injury like a contusion. You smash your finger in a car door, that is a compression-mediated injury. In the case of this gymnast, she probably over-rotated or under-rotated a dismount, landed on her head. Okay, so compression injuries are very severe, the potential for severe injury in the spine, because that compressive loading causes a decrease in the space and potentially puts the nerve at risk. Now, tension is frankly a little rarer in athletics. We've got a lot more compression than tension, and the best example I could think of that was the bottom end of a swing in gymnastics. And this is where the forces are attempting to pull that tissue apart. Okay, we do see this in sprains. So if you step off a curb, the two ends of your ankle ligament are affixed and they are stretched, and it will undergo a tension-mediated injury. But in terms of a macroscopic trauma, far more likely to have compression from impact than we are to have tension. Shear forces move across. So if we're saying the structure of the bone or the muscle or the tendon runs vertical, shear force runs across that orientation. Okay, so we've got an example here of a fellow doing leg extensions, and one reason we don't use this equipment in rehab for knee instability, ACL reconstruction namely, is that it induces shear forces into the knee. We unnecessarily load the ACL when we do these things because the femur is fixed, the tibia is somewhat free to move, and the muscles crossing the joint are actually loading them in such a way that we put undue stress on those healing structures. There are much safer and more functional ways of stressing the quadricep without inducing those same shear forces. Now, a bend force is where we've got 2 points, proximal and distal, of the tissue that are fixed, and we get compression forces along one side and tension forces along the other. In the case of this athlete, his hip is fixed, his foot is fixed in the turf, and he's struck by an opponent, and it results in kind of a macroscopic bend here. Lots of times this is encountered from structures that are already somewhat bowed. They already have this concave convex orientation. And what you see here is if we've got an axial load, okay, imagine you're trying to support the weight of a 5-pound plate using a soda straw. You're going to have load on top, you're going to have the fixed base at the bottom, and eventually that straw is probably going to crush and collapse. Okay. Another example here, we see a 4-point load where we have application that isn't necessarily directly in line with one another, and even more so true in the case of a 3-point load. And that's what we see here, where we've got fixation, fixation, and force in the middle. So bending forces can result in fractures, can result in a number of ligamentous injuries. Now, torsion takes this a step further by adding a rotation component. Okay, so in the case of this athlete, his foot is fixed in the turf, his hip is relatively fixed by the opponent, and as his body rotates, we get this twisting mechanism. So what we end up with here is a compression force on one side and a tension force on the other. Now, we know that being physically active, being an athlete, means that over time injuries are likely to occur. And we can classify them in several ways. One way is to talk about acute versus chronic injuries. When injury is acute, something has initiated that. So without question, this would be an example of an acute injury. When we don't know necessarily what initiated the injury process, or we do know what initiated but it doesn't heal, it can become chronic. Okay? We can also define an injury according to its mechanism. So this would be an example of a traumatic injury, whereas a stress fracture would be more overuse, where we've got the cumulative result of heavy loading manifesting itself as a fracture or as a stress reaction. Okay. Musculotendinous unit injuries have a high incidence of I want to say injury, have a high incidence of occurrence in athletics. Anatomically, we know that muscles are composed of contractile cells that produce movement. We also know that a tendon is non-contractile, but it's fibrous, tough. Those attachment points between the muscle and the tendon can be exposed to trauma through tension loading. The muscle itself can be exposed to trauma. So, key distinction to know here, and this is something I definitely want you to know before this course is over if you didn't know it already. We can't sprain a muscle. We can't strain a ligament. We sprain muscles. We strain muscles and we sprain ligaments. Okay, so a muscle strain is defined as a stretch, or tear, or a rip to the muscle and possibly even the adjacent tissue, the myofascia that covers and then encircles our small bundles. Now, the cause of a strain, sometimes we can't really pinpoint what causes a strain. It could be due to something as simple as an electrolyte imbalance. It could be the result of a strength imbalance that occurs due to poor posture. There can be a lot of reasons for it, but once they occur, treatment becomes pretty much the same. Okay, this can range from a very minute, microscopic, even separation of the connective tissue to a complete rupture, where we've got no continuity whatsoever between the muscle and its attachment point. So we grade strains and sprains on a 1 to 3 scale. And with a strain, the criteria are different than the criteria for a sprain, but they still hold true. Grade 1 is the least severe, grade 3 is the most severe. In the case of muscular injuries, a grade 1 involves some minor stretching, there may be some microscopic tearing, but we've got tenderness at the site, we've got pain on active contraction or range of motion. Movement hurts a little bit, but we can still get through the full range. Usually we can't palpate a divot or an actual macroscopic deformity here, but they are painful to the touch. With a grade 2, we've got actual fiber tearing, active contraction is still painful, maybe even more so, and there's usually a palpable deformity here between one side and the other. And something like this hamstring strain we see here, where they've got significant bruising, is probably a grade 2 or beyond. With a grade 1, we rarely, if ever, will have significant bruising like that would tell us there was significant tearing. With a grade 3, we've got a complete rupture. Lots of impairment here because that muscle is no longer viable active. If it contracts, it doesn't produce movement. There may be significant pain when it initially happens, and that may actually diminish because we're not moving the body part anymore. Okay, so pathologically, if we were to actually look at the tissue, a muscular strain is similar to a contusion or a ligament sprain in terms of the bleeding that's going to occur. So what we would expect to see with a grade 1 muscle strain may be similar to a grade 1 ligament sprain. I will tell you that bleeding and bruising like this tends to be worse in muscular injuries than ligamentous, simply because the vascular supply is much better in muscle than it is in ligament. Okay, so the time required for healing of muscle strains can be lengthy. It may take upwards of a year for full remodeling to occur. This often involves our large force-producing muscles. So in this case, this individual has a bicep rupture. You can see this kind of balled up bicep here and kind of a smooth, more gentle contour here. This tells us that one head's probably ruptured. Okay, usually with most minor strains, we may be talking about a month and a half, even 2 months before they start to feel like they're back to full speed. But keep in mind that if we return them to play too soon, that we can lengthen that process longer still. I've certainly done this. I remember in particular we had a tight end at one of the universities that I worked at, and he's definitely one that I tried to take along a little too soon. He was pretty tough, and I probably underestimated the severity of his injury, and he ended up just re-aggravating it more than once, and what should have taken a week or two ended up taking most of the season before he started to feel better. So I mean, it happens. We can misjudge. Cramps, on the other hand, we've talked about this a little bit with respect to heat illness and injury, but we can get cramps from other reasons. Sometimes athletes will experience these at night or when they're at rest. That may be an indicator of an electrolyte imbalance. These can occur in well-developed individuals when they are in a shortened position. Prolonged cramping can result in a strain. So if we've got an individual who has suffered from a heat illness that involves significant muscle cramping where they were in spasm for 10 or 15 minutes, they can suffer a strain. So they may be very sore the next day. We also know that guarding can occur, and this is where our body tries to shut down what's triggering an overuse injury or an injury of some sort. And so this is an involuntary contraction where the body tries to splint that area, and this may be in response to pain. Much like cramps, muscle spasms are a reaction caused by trauma. There are two types, clonic and tonic, and with clonic we've got alternating muscular contractions and relaxations where basically pulsatile in nature, and then tonic where they just kind of lock down and it's a rigid contraction for a long period of time. Lots of times muscle spasms in response to trauma, I mean, they can be either way, but most of the time cramps are going to be tonic in nature until we rehydrate them to the point where they stop. And much like we talked about with cramps, spasms can also lead to muscular or tendinous injuries because we're kind of locked into this maximal or near maximal contraction. We can actually self-injure. Muscular soreness can be a normal part of training. Most of you, if you're a kines major, you've probably trained. If you're an athlete, you've probably trained, and you know what that next day soreness feels like. There's a difference between overtraining and overextending. Okay, so overexertion in strenuous exercise results in muscular pain. This usually subsides on its own. Acute onset muscle soreness. Here we get fatigued, and we've got temporary pain that we feel right after we exercise. Lots of times in the case of overreaching and eventually in overtraining, we get what's called DOMS, delayed onset muscle soreness. This is that second day burn you've probably felt if you did a lot of sets. Usually pain-free 3 or 4 days later. I trained, today's Friday, I trained pretty heavily on Monday and Tuesday, and I could barely walk on Wednesday and Thursday, but today I'm feeling better. Okay, that's classic textbook delayed onset muscle soreness. What probably happened there is while we were training, we induced microtrauma, and that's not necessarily a bad thing, provided we give our body a chance to rebuild those structures that were traumatized. If we couple intensive workouts one right after another and we don't give time to rebuild, then we end up overtrained. Okay, so if we are consistently noting that delayed onset muscle soreness, then chances are we are overprescribing exercise. And we can prevent or at least minimize that soreness by more gradually building up intensity. Okay, tendon injuries, we see these from overuse and acute as well. Lots of times we see acute injuries in older athletes or those who have had significant chronic injuries. So if they've had Achilles tendonitis for several weeks, for instance, then they're more likely to suffer a rupture. Okay, tears generally occur in the muscle and not in the tendon. The tendon is not the weak part of the musculotendinous unit in most healthy folks. And we see there's really not a lot of yield in that tissue. It's not very elastic. Tendon are kind of akin to steel cables. They really don't give much, and they can transfer a tremendous amount of force without breaking. Okay. Ordinarily, tendon has this kind of wavy parallel arrangement, healthy connective tissue tendon. In a diseased state, we end up with this disorderly arrangement. Okay, so instead of this striated waviness, and the waviness allows slack to be taken up, we end up with this kind of mop head look. Okay, repeated microtrauma may turn into chronic strain because our body doesn't lay that tissue back down the same way that it initially was. Okay, so we want gradual loading because our body will initially lay in some kind of nondescript connective tissue just to heal the void, but it takes loading in order to get remodeling that will make it look more like it looked before it was injured. So complete rest is not what we're after. We're looking for gradual, controlled loading and conditioning so that eventually this injured or diseased state starts to look more like it did before we were hurt to begin with. All right, now we hear the term tendonitis thrown around a lot. Anytime you see this suffix itis, we think inflammation. Okay, tendon. So tendonitis is an inflammation of the tendon. Now, anytime we've got acute inflammation, it's usually only going to last maybe 10 days, 2 weeks at the absolute most. Okay, without proper healing, this condition doesn't just stay as a simmering inflammation. It starts to actually turn into degradation. So tendonitis starts to become tendinosis, and we'll talk about that one in just a minute. But it's different. We don't treat tendinosis the same way we treat tendonitis. If it's an inflammation, we can treat it with anti-inflammatories. If it's not an inflammation, then taking anti-inflammatories is a waste, and it's just being hard on their kidneys for no reason. Okay, the key to treatment here is optimal loading. Some would say rest, but as we said in the previous slide, optimal loading, we're not making the condition worse, but we are putting some load through it, will stimulate that remodeling that we're after. Tenosynovitis is an inflammation. Again, we see the itis suffix. Teno refers to tendon. Syno refers to the synovial tissue that bundles or otherwise wraps around the tendon. So this is not an inflammation of the tendon itself, but rather the sheath. Okay, we see these in the thumb quite often in stick and ball sport athletes. So this patient's being injected in the tenosynovium of the abductor pollicis longus. This is an acute inflammation, and anti-inflammatories are usually pretty helpful in knocking these out. Okay, myofascial trigger points, these are the knots that you get in your neck from time to time, and they're not just in the neck, they can be anywhere. These are hypersensitive nodules that basically are local areas of spasm on a microscopic level. So poor posture can lead to these, improper movement patterns, any number of things can be the trigger here. But if we have these and we don't treat them, then our posture tends to be worse and our mechanics tend to be worse. So lots of times in athletic training, if we have these, we'll treat this with massage, we'll treat this with foam rolling, we'll treat this with other types of manual therapy to try to get these out, because if we leave them, they can start to lead to other problems. Okay, these are classified as latent or active. Latent basically means they're kind of old and they stick around, whereas active, usually these are kind of like we talked about with delayed onset muscle soreness. These come about as a result of activity and are sometimes easier to resolve. Okay. An active trigger point causes pain at rest as well. If we apply pressure and we get pain, we may get what's called a jump sign, where the patient will kind of flinch. These may be tender to palpation with what's called referred pain. So if we poke on their shoulder, they actually feel pain shoot down their arm. They may have a tender point locally versus a trigger point, where pressing on the trigger point causes that referred pain. Okay, we see these most often in muscles involved in postural support. Most of the time, usually it's going to be the traps, muscles in the back as well, rhomboids, serratus anterior to a certain extent, but they can occur in pretty much any muscle. Okay, a contusion is a result of a sudden blow to the body. This could be from an opponent, could be from a stick, ball, puck, could be, any number of non-yielding implements or body parts. These can be deep or superficial. Deep contusions involve deeper layers of the skin, and either way, our concern here is whether or not we have a hematoma, and this is a collection of blood in the muscle tissue. Is our biggest concern here. If we get a hematoma in our quadricep, one particular concern we have is that we actually start to get some calcium deposition within that hematoma. Don't really fully understand the process through which this occurs, but we can end up with bone formation in the muscle tissue, and that's not a good thing. So if we've got a significant contusion, we'll put a compressive bandage or dressing on that, ace bandage with a thick piece of foam or felt to try to force that swelling out of there. We'll use things like ice massage, gentle stretching, gentle massage to try to get that hematoma out without making it worse, so that we don't end up with that ectopic bone formation. That leads us to joint injuries. Each joint has both hyaline or articular cartilage and then a fibrous connective tissue capsule. The synovial joints themselves, we've got the capsule and then thickenings of that capsule, or sometimes separate ligaments altogether for support. That capsule is lined with a synovial membrane. We've got hyaline cartilage that is smooth and slippery that facilitates movement. That joint cavity is filled with or contains synovial fluid. And then we've got blood and nerve supply with muscles across the joint that serve as dynamic stabilizers. In many joints we may have, or in some joints we may have menisci. So the knee, for instance, we've got fibrocartilage that provides added cushioning to that joint. All right, now I already said muscle injuries are referred to as strains with a T. Ligament injuries are referred to as sprains with a P. This is a result of any of those mechanisms of injury that we talked about, but oftentimes there's a twist or a stretch that results in tearing of the connective tissue. The grading is much the same, grade 1, 2, and 3, where we've got minor, kind of microscopic, all the way down to macroscopic complete failure. All right, now our signs and symptoms of sprains include joint effusion, if it's a joint like the knee where we've got a significant joint capsule, that's swelling that's contained within the joint, or just swelling external to the joint. edema. There may be a local temperature increase where we've got blood accumulating there. They may have pain and point tenderness, ecchymosis or bruising, and we want to make sure we can rule out what's called an avulsion fracture, where the ligament itself is intact but the attachment point on the bone is actually broken free. The biggest difficulty with minor sprains, grade 1, grade 2 sprain, is restoring stability after the injury, after they've recovered, because the tissue's stretched out and then we end up with inelastic scar tissue. So to get stability, we've got to add strength to the dynamic stabilizers. Ligaments are what are referred to as static stabilizers. They don't change, and if they're stretched, we can't contract them. They're pretty much left elongated unless we have surgery. Whereas a muscle is a dynamic stabilizer, where added strength, particularly added strength and added motor control, can add a lot of stability to supplement that loss of static strength or static stability. With a dislocation or subluxation, basically kind of two flavors of a similar injury. A dislocation involves a complete malposition of one bone relative to another. These can sometimes spontaneously reduce. In other words, they go back into place on their own. With a subluxation, it's a partial dislocation or an incomplete separation of the two bones. Sometimes it's largely academic. Was it spontaneously reduced dislocation? Was it a subluxation? Sometimes hard to tell. But either way, we're going to treat these very, very similarly, where we, especially for a first-time dislocation, subluxation, we're going to treat it almost as if it's a fracture and make sure that there aren't other complications associated with that. The stabilizing structures, the ligaments and the capsule itself, are disrupted here, and the joint is going to become susceptible to recurrent dislocations for the reasons we just talked about. That connective tissue becomes stretched, elongated, scarred, not as likely to protect the body against force as it once was. If we're concerned that they have had a dislocation, then an x-ray is the only way that we can rule out bone fragments or an avulsion fracture or other issues at the joint. Once a dislocation, always a dislocation. You see that quote at the bottom there. That just basically means that once we've sustained that injury, with the exception of whether they have reconstructive surgery or not, they're probably always going to be prone to dislocation. Another synovial joint injury we are concerned with is osteoarthritis, and here's where we've got wearing away of the hyaline cartilage on the ends of the bone as a result of normal use. Next time you eat chicken wings, take a look at the ends of the bone. You'll see that slippery white cartilage on the end, and it covers the entire bone end. With osteoarthritis, we get a wearing away of this cartilage so that the underlying bone shows through. And symptoms of this include pain, usually activity mediated. The more we do, the worse it is. Relative joint stiffness, and as well as pain with any kind of weight bearing. Lots of times they'll have pain in the morning before they get going, and then they may have sensations of creaking or grating. This can either be generalized within the joint or localized to one particular side of the joint. So in this instance, this would be a medial condyle on the femur that's kind of worn away, and we might just notice pain on just that one side. Okay, bursitis, on the other hand, as opposed to osteoarthritis where we've got articular cartilage injury, this is an irritation of the bursa. And bursa are small fluid-filled sacs that protect against friction and provide lubrication for motion. Ordinarily, they're very, very small, so you can think about bursitis as almost like if you've seen the little plastic screen protectors for your phone and you put a drop of water between them. They'll kind of slide on one another very easily. That's what a normal healthy bursa is going to be like. But in the event of a traumatic bursitis, we end up with that structure being compressed or otherwise traumatized, and it will swell up, and it's more like a water balloon at that point. So because it's larger, because it's taking up more space, it's more likely to be traumatized again. The bursa is sometimes referred to as the alarm bell of the shoulder. We'll end up with bursitis before we end up with a more severe condition such as impingement syndrome, tendonitis of the rotator cuff, things like that. Bursitis is very easy to treat in terms of the symptoms, but it's not as easy to treat in terms of the source. So we call it the alarm bell because usually it will get irritated first if we've got poor mechanics. We'll see this in throwers quite a bit. Baseball players will end up with bursitis from time to time. In this instance, you see an elbow bursitis. This could result from a fall. See this in basketball a lot. Player will dive for a loose ball. They bang their elbow on the floor, and they end up with this big swollen fluid mass on their elbow. Capsulitis, on the other hand, this is an inflammation of the joint capsule from repeated trauma. Synovitis is an inflammation of the joint lining. So we see this kind of redness. This is an arthroscopic surgery, and we see this kind of red, proud lining that's clearly inflamed. They may end up with thickening, and synovitis can turn into capsulitis relatively easily. That capsule can thicken up, and we start to end up with what's called a capsular pattern, where we lose range of motion in a characteristic way. Bone injuries, on the other hand, these can be classified as closed or open. With closed, we've got relatively little movement or displacement. With open, the bone ends jut through the skin. This is a serious condition if it isn't managed appropriately. It can result in what's called a non-union, where the bone ends fail to grow back together. My son just broke his tibia and fibula a couple weeks ago. I'm going to pause it, see if I can find that picture. So here's the x-ray. Hopefully you can see that.
Of his closed fracture. And there you see the deformity. So clearly the bones were broken, but they didn't jut through the skin. He was at a trampoline park here in town and landed awkwardly and sustained a fracture. So you see things like deformity, obvious pain, point tenderness, unwillingness to bear weight. All those are possible signs. Sometimes it's real difficult to distinguish between a sprain and a bone injury, especially if the potential fracture is closer to the joint line. In his case, it was kind of distal third, but it wasn't close to the joint, so we knew pretty much right away that it was not an ankle sprain. It was in fact a tibial fracture for sure, and a fibular fracture quite possibly. Mechanism of injury for bone injuries: we can have a direct, where we've got force application. So you're hit in the face with a line drive, then that ball causes a direct fracture. Or it can be indirect, from that bone being applied force. It can also result from sudden, violent, forceful muscular contraction in the case of an avulsion injury. So several different types here we see. In the case of skeletally immature patients, green stick fractures are relatively common. Comminuted fractures are basically where we've got shattering and there are bone fragments, usually sharp. These are highly likely to become open. Linear fracture, where it is in line with the long axis of the bone. Transverse, where it's perpendicular. An oblique non-displaced fracture, that's what my son had, where it's between two planes. Spiral fracture, where there's rotation. These are less likely to line up and reduce cleanly, and lots of times more likely to need surgery. An impacted fracture, we don't have a picture of that, but that's basically where we get compression of the growth plate. And then a depression fracture would be like we would see in an irregular bone, a scapula, or a bone in the skull. Other types we can see, and there are pictures of these in your book: blowout fracture, serrated fracture, depressed contrecoup fracture. You can take a look at those when you're reading through and see those examples in your textbook. Another type that we see quite often in endurance athletes are stress fractures. And so my son had an acute injury, and
He and I were training for cross country. He runs cross country. I thought I'd help him this season, and so we were running 4, sometimes 6 times a week. And I developed stress fracture in my tibia. So he's in a long leg cast, and I can't run, but I can tell you from experience how this occurs. Overload. I was running more than I was used to. I'm heavier than I've been, and I was running too often. I tried to run through pain. I thought it was just soreness, and eventually ended up with a stress reaction, which is kind of a precursor to a stress fracture. Uh, Athletes are susceptible to this particularly early in training because the muscular forces are higher, their body weight may be a little bit higher, and they may pick up training where they left off, thinking that their body can accommodate when in fact it can't. Okay, so this progression starts with focal microfractures. They're not going to show up on an X-ray. The periosteum and the endosteum surrounding the bone becomes involved, and then we end up with a response that probably is viewable on an MRI or a bone scan. And in this example, we see this dark mass. It's not really a mass. What's happened here is the patient's been injected with radio tracer, and then an hour or two later they are scanned, and so these dark lines you see, this tells me this is a younger athlete because they've got bone activity occurring in the epiphyses of their long bones. But what we notice here is on the left side there is a dark mass in the midfoot, and there's not one on the right side. So that tells me that there is osteoblastic activity going on here, and there's remodeling attempting to occur here. So that's exactly what a stress fracture is. Okay, we can't see that under a normal X-ray. It has to be under a bone scan ideally, but we can also see this under MRI. Typical reasons we get these: we return to play too soon after injury, changing events without conditioning, starting the initial training too quickly, going to a non-yielding surface. We were running mostly on track, on a rubber running track, but I noticed that in particular running around the neighborhood was worse. Well, it makes sense now because running on asphalt is less forgiving than running on a rubber track surface. Could also be a result of poor footwear. Non-supportive, non-cushioned shoes may play a role. Usually early on we'll have focal tenderness and pain, pain with activity later on, pain after activity later on, and then eventually constant pain. Common sites are the tibia and the fibula, lower extremity in particular. But we can also see these in the ribs, the pars interarticularis, which is a portion of the spine, vertebrae more specifically, and then in the humerus. We see this in throwers sometimes. Management varies quite a bit, but more often than not, the primary thing we have to do is remove the stress that caused it to begin with. In skeletally immature athletes, another thing we need to be concerned with are traditional fractures that involve the growth plate, because it can disrupt growth and result in a length discrepancy depending on the bone. We'll see this in kids 10 to 16. As I said, my son, he's 11, and he had what's called a type 2 Salter-Harris. Okay, so the types here, 5 different types, a little mnemonic to remember them. If we've got separation between the epiphysis and the diaphysis, that's a type 1. Those heal almost 100% of the time. Because that's an active bone growth site, as long as we get those 2 bone ends back in place, then it will heal. In the case of a type 2, here we've got an above. So the name Salter, use that as a mnemonic. S means separation. A means we've got a fragment above the joint line. Type 3, we've got a fragment lower than the joint line, the L in Salter. Type 4 is through. It's all the way through the top and the bottom. These are particularly complicated. In a type 5, even more so, and healing becomes increasingly problematic depending on which of the types we have, 1 through 4, 1 being the simplest. Type 5, we get the growth plate crushed shut, and it may stop long bone growth at that point. Okay, apophyseal injuries, we see these. The apophysis is the muscular insertion. Um, Apophysis is a traction epiphysis. Okay, we end up with tension across this. We see this in growing athletes. Their long bones are growing, their muscles are kind of struggling to catch up, and we end up with something like this. On Osgood Schlatter's, we've got a big prominence on the tibia at that tibial tubercle. This can be painful sometimes. If you've had a big growth spurt, you've probably experienced this yourself. Uh, at the knee, Osgood Schlatter's. At the foot, Sever's disease. Basically the same general injury process, just occurring at two different spots. Okay, osteochondrosis or osteochondritis dissecans. This is where we end up with chunks of cartilage or fragments of cartilage in the joint, sometimes called joint mice or a loose body. These can include several different injury-causing mechanisms, but the symptoms here are much the same: pain, swelling, disability, catching and locking, clicking, those kinds of things. These may occur in addition to something like a meniscus injury that will also click, catch, and pop, so it may be difficult to tell which one's causing which. Okay, that leads us to nerve injuries. Here we've got an abnormal Here we've got an injury that results in an abnormal sensation more often than not, either numbness or tingling, burning, those kinds of things, radiating, sharp shooting pain. All those types of sensations are usually attributable to nerve as the source. Most frequently we have what's called a transient neuropraxia. Transient means it's temporary. Neuropraxia means we've got abnormal nerve function here. We can also get a compression of nerve, a stretch of nerve, a laceration that involves nerve. All these can impact nerve function as well. With most of our athletics related nerve injuries, compression or tension are our primary mechanisms here. In the case of something like this, you know, we certainly see this athlete who's suffering from the effects of the hit, but what we don't see is the athlete delivering the blow. They're being compressed on the right shoulder, their head's being forced to the left, and that could induce a stretch injury or a transient neuropraxia here. Nerve injuries can be relatively minor and go away within moments, all the way to paralysis. Okay. We'll discuss nerve injuries in greater detail as we get deeper within the core, especially in the shoulder, when we talk about injuries there. But just understand that those characteristic descriptors of pain, sharp, bright, shooting, those oftentimes would tell us that it's a nerve-based pathology. All right, last slide here. Microtrauma and overuse syndrome. Injuries that result from abnormally high stresses, repetitive stresses, micro traumas that we can't see on x-ray can fall into a class with these identifiable syndromes. Okay, you'll hear it described as golfer's elbow, tennis elbow, runner's knee, cyclist's knee. All those terms that are associated with specific sports are, in essence, if you really boil them down, they're overuse injuries. Okay, we see these in running, jumping, throwing activities. Some can be relatively small but very debilitating, and it's difficult as the athletic trainer to figure out when it's appropriate to remove them from participation and try alternatives to training and participation, and when to go ahead and let them try to participate through. In my case, I've had a knee injury in the past. I remember exactly where I was most recently when my knee pain started, so it didn't fit the normal progression of a stress fracture. So it really never crossed my mind that that's what I had. I assumed I had a meniscus injury that I had worsened from running. And so I tried to push through the pain, thinking that, if it's minor, no big deal, and if it gets worse, I might need surgery to clean it out. but when in fact I had a stress reaction going on. And had I realized that, I would have altered training, and hopefully I wouldn't have had to sit out from running for 6 weeks. Lots of different repetitive overuse stress injuries. We're going to talk about these as the course goes on, but just know that for now, understanding the onset and the progression of these conditions is important for any coach or athletic trainer to be able to recognize, because we need to intervene, because if we don't, then they're going to get worse before they get better. They're going to miss practice. They're going to miss games. All right, well, that's it for this week. Don't forget, you've got we're reaching midterm here now, actually, so quiz this week, and actually a midterm coming up in a couple of weeks. So stay up and make sure you read your textbook. Check out all the other resources that are available for the course, and if you've got any questions, give me a call, shoot me an email.